So I'm sort of going to walk through very practically our approach at the University of Colorado to pulmonary valve replacement, transcatheter pulmonary valve replacement. This isn't the most straightforward case. I added this case because it has some nuance to it and allows me to sort of discuss some of the challenges and things to watch out for. So in general, we'll cover sort of what our approach is to pre-procedure imaging, access, the wires that we use for delivering the device sizing, which is very different from what most of us are familiar with TAVR, and really highlights the need and the evolution of these therapies from where we started to where we are today and hopefully where we're going. The role for balloon sizing, which we generally don't use in the aortic valve position, and really importantly, the nuanced determination of coronary compression and how to interpret those findings. And then we'll go through the delivery and deployment of the valve, and finally, closure and post-procedure care. So I'll present the case of a 30-year-old woman. She's got a history of tetralogy of Fallot. She actually had a classic right BT shunt and subsequent transannular patch as an infant. She's had issues with ventricular tachycardia and had an ICD placed. A lot of branch pulmonary artery stenosis and has had multiple interventions with stents placed in bilateral branch PAs at the ostium as well as the segmental branches of her pulmonary arteries. She's had long-standing moderate to severe pulmonary insufficiency with some subtle progressive symptoms. So pre-procedure imaging in the pulmonary valve space is a little bit different from that in the aortic valve space in that once we do a CT scan for someone who's going to have TAVR, we already have the indication. We know they have severe aortic stenosis, and we know that they need an aortic valve replacement. Whereas with pulmonary valve insufficiency, especially in someone who's got congenital heart disease and has long-standing PI from either a valvotomy or transannular patch, it may not be clear when to actually time these interventions. And imaging is really helpful, and there's some data to suggest that there's RV volume cutoffs at which in asymptomatic patients we should move forward with pulmonary valve replacement. It allows us to determine the anatomy, most importantly what the prior repair was, whether there's a valve conduit, a bioprosthesis, or whether it's a transannular patch and what the location of that patch is, the proximity of the coronary arteries to the right ventricular outflow tract, which becomes really important and is one of the more common reasons to abort these procedures. And sometimes it's pretty nuanced where coronaries look very far away on cross-sectional imaging, but you get in and do testing and it's abnormal. But some anatomies, especially most commonly an anomalous LAD from the right coronary artery which runs across the RVOT, those are clear sort of upfront contraindications that you know you're not going to be able to do this before you subject the patient to a procedure. And in the end, really, we're determining whether the anatomy is suitable for transcatheter pulmonary valve replacement. So here's our echocardiogram. For those who don't do a lot of congenital heart disease imaging and echo interpretation, severe PI is really easy to miss, and this is pretty demonstrative of that. So when you look at color Dopplers with severe PI, this happens quite commonly where patients get echocardiograms done in the community where folks don't have experience with congenital heart disease, and it gets interpreted as no or mild PI because the duration of the pulmonary insufficiency without a valve there is so short that it's really easy to miss by color Doppler. So firstly, you have to sort of think about it and know that it's a possibility. And secondly, spectral Doppler is really important here to sort this out very clearly. You have severe PI with early normalization of pressures. So here's a CT scan that'll run through. So you see the transannular patch there with the calcium. I'll let it run through again just so we can orient ourselves. So here's her RV. It's moderately to severely enlarged with an end diastolic volume indexed of 172 mLs per meter squared, which is pretty big and sort of above the cutoff where we like to do this. So both PAs are stented, so branch PA stenting, and that becomes important when we look at the imaging from the case and something to be cognizant of if patients have branch PA stenting, because it can make parts of this procedure very challenging. And you see in the area that's very anterior behind the sternum, you see this patch here that's very calcified. So this is the reason why the surgeons didn't want to operate on her. So essentially a patch and RVOT plastered up against the sternum, high risk for bleeding issues and needing to go on pump before you even open the chest. So thought that transcatheter pulmonary valve replacement was a good first start. So pulmonary valve sizing. So in bioprostheses, this is pretty easy. We use the Valve and Valve app. the congenital interventionalists like to balloon size things, so even if we know what size bioprosthesis it is, we oftentimes will balloon size just to make sure there's not significant pannus ingrowth, to make sure we get good expansion of the valve. But really what we do in native RVOTs and patches, we'll take angiograms. Biplane is really helpful in this as opposed to other transcatheter valve replacement. I wouldn't say it's absolutely necessary, but it makes life easier and spares contrast dose because you need these two views to make accurate measurements. So we'll measure both with catheter across and native measurements, and then we'll also balloon size. So we usually take a 40 millimeter, 30 or 40 millimeter, depending on the size of the conduit or pre-procedure imaging. This is a PTS sizing balloon. And we'll go ahead and sort of inflate to the point where we have a waist, and then we'll go ahead and measure the waist. So I'll just point out, you notice that the nose of the balloon is actually into the LPA stent, which low pressure balloon inflation, it's fine, but it'll become important later to be aware that this is interacting with that stent for two reasons. Number one, valve positioning, and number two, what I'll show you happened in this case, which is balloon rupture. So here's our measurements. We oftentimes will verify these. They're not always accurate, so I will usually go on our CT measurements and then balloon sizing, but clearly above the range of a Melody valve, which maxes out at 22 or 24 millimeters if you really push it. So clearly a Melody valve is not going to work here. So same concept, we'll reinflate the balloon and then test the coronary. So the right coronary artery is well out of the way, no need to test that, but the left coronary artery, of course, relatively closely, not super close, but a lot of times we see tissue movement in block. So even if it's very remote from the RVOT, we'll see sort of tissue in the mediastinum get pushed and indirectly compress the coronary. So even if it looks by CT like it's a mile away, it's important to do this because this is really a life-threatening complication. And it's essentially like TAVR. It's really hard to rescue this because once it's compressed, it's hard to wire, it's hard to get equipment down, so it's best avoided. In terms of delivery system management, so this is the Edwards SAPIEN 3 delivery system. It's a commander delivery system with the E-sheath, which is the case I'm going to show you. Very different than TAVR in terms of sheath positioning, valve loading. So in TAVR, we always advance the sheath to make sure that the white portion of the sheath is in the vessel. With transcatheter pulmonary valve replacement, you have to leave that sheath hanging out because you're going to load the valve onto the balloon in the IVC. If you put the sheath all the way in, you're going to be in the right atrium and you're not going to be able to load the valve. So it's important to leave it out up front so that you don't dilate your venotomy and have bleeding. Just something that's a little bit different. The commander delivery system is night and day, 100% improvement over the old NovaFlex system, which was really stiff and difficult to deliver. It actually tracks pretty well, and we've not had much trouble. So here's valve deployment. Just to go back, crossing the valve is done with a balloon-tipped catheter to avoid getting entangled in the tricuspid valve chordae and the trabeculations in the ventricle. And we use a Lunderquist wire. And good wire position is super important with pulmonary valve replacement. So you have to be very deep in the PAs or else you'll lose wire position because there's a lot of manipulation in the right atrium usually to get these valves in place. So we actually took a Edwards SAPIEN 3 29 millimeter valve and put +5 in the syringe. Some of our CT measurements were over 30 millimeters, so we thought that we needed to be pretty aggressive with sizing here. And what you notice is, so a very slow valve deployment. The balloon's a little bit back in the valve, which is why it sort of expands from the ventricular side first. And what you notice is that full deployment here, the balloon actually ruptures. It's essentially perforated by that stent. Balloon ruptures are potentially a problem. We've had some balloons shear off, and oftentimes when they rupture on their own, they rupture circumferentially and become like an umbrella, and we've had sort of disarticulated balloons that we've had to snare. Fortunately with this, it just perforated the tip, so the balloon was intact and we were able to get it out pretty easily. In light of that, we weren't sure whether we had stable valve position because the balloon did rupture, so we went back and post-dilated with a 30 millimeter Z-Med balloon, which wouldn't be my choice today. With true balloons, I'd probably use a true, but that's what we had at the time. And notice that we have full valve expansion. In terms of imaging, we use a multi-track catheter over the wire so that we can maintain wire access in case we need to post-dilate. So multi-track goes into the main PA, and then we take angiograms. And you'll see here that there's really only catheter and wire-associated pulmonary insufficiency, and looks like good leaflet function. And we always measure the valves at the end just to get a sense of whether we're fully expanded. In this one, we got pretty close to 29 millimeters. So in terms of closure, I only show this because there's one of my colleagues is from Great Britain, where money is a big concern, and the figure of H stitch, which I put in the medieval torture devices. Patients hate it, and I think, frankly, the data supports using pre-closure of veins. I don't think there's a higher risk of complications. So this is what I would recommend, pre-closure the same way you do with TAVR for venotomy or MitraClip in the vein. Or if you really want to be terrible to your patients, you can do that and go inject Lido every 2 hours overnight. But it works, but I think it's, I think it's easiest just to put a couple per-closes in and get out of Dodge. Post-procedure, you see that we have good valve function, no pulmonary insufficiency, acceptable gradient, so means. Means usually we get with the sapien valves in the low teens with pulmonary valve procedures, and patient is doing well. So just to highlight a couple things, ICD leads are really important to be cognizant of. We've dislodged more than one. Her device was at end of life, so she needed a replacement. So it's important not to do that before you do this. So do this first in case you knock a lead out, and the last thing you want to do is knock a fresh lead out. And really, I can't overemphasize the need to have an iterative approach to pulmonary valve replacement. It's not like you lock in with a size and know up front, especially in native RVOTs or patches. It's really a dynamic process. Some of these could be very pulsatile and very compliant, so it's important to balloon size and make sure you test the coronaries. Thanks very much.